Welcome to Swift Coaches Academy, a podcast dedicated to bringing exercise and health professionals the uncensored truth behind what it really takes to succeed in the health industry with me, your host, Zenia Wood. As an accredited exercise physiologist and the founder of Swift Coaches Academy with almost a decade of experience, I'm on a mission to transform the lives of ambitious health professionals who want more and are ready to take action to create incredible impact and financial freedom. So join me as I speak candidly with industry leaders about the struggles and successes from within the trenches through thought-provoking conversations.
Today, Zenia's conversation is with one of Australia's leaders in knee rehab, Adam Walker. As a practicing physiotherapist and PhD researcher, Adam provides unique insights from his studies and integrates these to create better outcomes for his patients. If you're keen to better understand common knee conditions, you need to hear this episode.
Adam Walker, or should I say one of the leading experts in knee rehab, knee research. How are you?
I'm going well, thanks, and I appreciate the compliments.
It's okay. I know that obviously, you and I do mentoring together, and that's how we met. And you're working on actually talking about, your professional qualifications and just the amount of research you've done is incredible. And I know that, you don't give yourself enough credit for actually how exceptional you are in the space of knees and, being one of literally a handful in Australia who are literally leaders. I am honored to have you on.
Yeah, thanks. Yeah, I appreciate that. It's been obviously it's been a fair few years now, really just focusing in mainly on around the knee injuries. So after, I think, like you say, after you spend enough time reading and researching and seeing people, then hopefully I've got a fairly good idea about a few different things about the knee.
I would say probably definitely more than almost or everyone, but most people for sure. So can we go into your background a little bit, what your qualifications are and sort of how you got to where you are now?
Yeah, absolutely. I guess, well, I grew up in Tassie, if we want to go way back, but that's where I did my exercise science degree. So I started with an exercise science degree, like a lot of us obviously in this profession. And then I finished that down there. After I did that, I actually went and became a personal trainer for a year. So I think the value of that year that I had after my undergrad was really valuable, just to be able to obviously see a wide variety of people across the general pop just in a usual commercial gym. So that, and then in that year I was trying to figure out what I wanted to do, because as you're probably aware, you kind of finish your exercise science and, do you want to do physio or sports science or nutrition or exercise physiology? So I went down the physio route. So that's when I moved to the Gold Coast and did my physio degree at Bond Uni. So after I finished that, I got a job straight away and went into private practice. So I've been working across a couple of private practices here on the coast now for the last just a bit over 7 years now, really. So it's been some time and it's been some really enjoyable. And at the start, I think it was really important for me to spend the first 2 to 3 years just seeing anybody and everyone, and was doing lots of sports teams work at the amateur level, did some other travel with some sports teams, and was heaps of PD, all that kind of stuff that everybody kind of has to do if they want to get somewhere. And then after the first 3 years, I then was doing a lot more regarding return to sport testing, and a large portion of that was on athletic knee injuries, so predominantly ACLs. So I just started to develop a real keen, I guess, clinical interest in ACL injuries. So as a result, was either going to go down this kind of sports titling route as a physio, or after speaking to a bunch of mentors and people I obviously respect, I decided to do a PhD because I feel like that was better for my future. So I've been doing that now for the last 4 and a bit years, and I should be wrapping up that in the next 6 months. So that's where I've looked at a lot of things regarding ACL injuries, with the primary kind of premise around it, I guess, is that most people after ACL injury, unfortunately, drop out of rehab. We find that a lot. Somewhere between 3 and 6 months, there's a huge dropout rate, and most people aren't getting back the function they need to return back to sport. And then they either don't return to sport because they never feel confident, or they're still having issues with their knee, or they go back, have ongoing pain, or in a lot of circumstances, they actually re-injure it again. So it's just conducting some research in how we can improve our clinical practices to help people actually get back to sport, because that's the reason you have an ACL surgery in the first place.
Yeah. And so, sorry, you go.
The final thing there is probably 2 and a bit years into that, I kind of formalized that into Gold Coast Knee Group, which now predominantly my clinical load is probably close to over 90% knee patients, and that's from sports knee injuries to whereas older individuals with knee injuries, osteoarthritis, meniscus tears, ACLs, MCLs, all those kind of things. So that's just my huge clinical focus at the moment is people with knee pain.
That's awesome. And so you said something about, like, obviously, you know, looking to drop out in terms of your research. What, if we can have some spoilers, what have you found that helps support people to reduce dropout rate post ACL?
Yeah, I did. So there was a systematic review and then a focus group look at just talking to people about what they found difficult. And naturally, there are a multitude of factors that can contribute depending on the person's circumstances. But the big ones are, from a systems level, there's almost the way that private physiotherapy is structured here in Australia. There is a diminishing attendance, or even how often we see people as rehabilitation progresses, and that just creates a disconnect, I think, between the physio practitioner and the person, and they're getting to this stage in kind of 3 to 6 months where they actually feel okay. So the significant deficits that they've likely still got are still present, but it's just not front of mind anymore. So that's where things like really good goal setting procedures, making sure they're really clear on goal setting from a patient perspective, but also from a practitioner in terms of what physical milestones do they need to be hitting before they can progress on, and having those frequent touch points so that they have a really good understanding of where they actually are in their rehab, and supporting them through that kind of journey. And then off the back of that, then it's about setting up appropriate programs and systems that provide education to the patients so that they're constantly informed of what they're doing and why they're doing it, but also the systems that
I didn't get that. Could you try again?
We've got Siri coming on.
Also just trying to figure out what systems you can put in place so that they can have the supervision required, particularly in the later phases of rehab, to actually hit the physical milestones, because it's very, very hard for an individual by themselves to regain sufficient function to normalize their knee after an ACL reconstruction without appropriate supervision and guidance, particularly in the late phases.
Yeah, gotcha. So, oh, sounds a bit echoey. Is that happening on your end too? No, okay, we're good. All right.
Good.
Mikey, please edit that last bit out. He's our editor. So the early stages, people seem pretty keen. Obviously, they've just had surgery. They're, you know, ready to get back into it. But it sounds like that later stage, if there's not, you said, that structure in place and they're educated, not just at the start, but through every step of the journey to have milestones just, you know, 1-2 steps ahead.
Yeah, I think that late stage from kind of 6 months onwards is most important, because a lot of people use up either their private health coverage or they feel that the costs are starting to build up, and the really obvious restrictions that you have post-operative aren't there anymore. Yeah. So we just lose touch in those later phases, which is the most important time where you should be just performing a really good strength and conditioning type protocol to actually achieve the deficits, because most of the time it's hard to load sufficiently in that first periods anyway, because we're overcoming the post-operative stuff, which is fine. So we can get to a point, but we're just not going to get there. So I would almost think that last 6 months is more important than the first stages.
And do you think that people maybe undervalue the strength and conditioning aspect and the change of direction and all that sort of later stage return to play work, and maybe overemphasize the early stage stuff because of the physical impairment that's so obvious to them?
Yeah, I think it's on both sides of the coin, really. I think most people, if our dominant kind of clientele is from 14 through to 25, a lot of those people aren't familiar with what actual strength and conditioning training involves and what it takes to get strong, powerful, and build up your or address the deficits associated with it, because they're used to just doing regular just gym-based training, whether it's group fitness training or going to the gym for your hypertrophy-based work like most guys do. So I think there's that side of things. And then I think there is, which I think is changing a lot now, particularly in the last 5 years, is from the physio's side is obviously we're ultra comfortable in that early to mid stages, and then we probably lose a little bit of knowledge towards the back end. And there are definitely physios around that have excellent skill sets in that regard, but then there is definitely probably a key area that we're trying to develop as a physio profession, is being able to have skill sets or the awareness and the knowledge to refer to someone with an appropriate skill set for that last stages, because most clinics are probably not set up to be able to achieve what you need to in that last stage. Anyway.
Yeah, I totally appreciate that, because I was going to say, do you think physio is the best person to take them from day one to the field? And I think, obviously now understanding that you have an exercise science undergrad and you did personal training, like obviously you've got a great understanding of that later stage or just general strength and conditioning principles. But my understanding is that physiotherapy's main focus is the acute injury management, regardless of the condition. And so it's kind of teaching them how to be exercise professionals. And obviously, it's still within scope for a physio to be able to do some of that. But then when it comes to the S&C work, if that's not their prior background, maybe it is best to refer on to an ex-phys or to a sports scientist or even a personal trainer who can run through general strength and conditioning principles, if they have obviously a framework to follow and they have the metrics that they need to hit at each phase.
Yeah, I think it comes up to the individual, like the clinician. For them, if that's their interest area, then they have to develop the skills in that area. And to be honest, working within a private practice setting, most kind of average physios, not average physios in terms of skill set, but generally across the physio kind of broad, most people are probably seeing maybe 1 to 5 ACLs a year. Like, it's not actually that much when you distribute it across the wider physio community. And if only 30% of those are doing rehab past 6 months, then you might only be seeing one person, maybe 2 people each year with an ACL in the later stages. So there isn't that. It's hard to develop the skill set when you're trying to maintain a caseload and service everybody, but then you're only seeing a couple of these patients every year anyway. So it makes it really difficult if you're working within a private practice, unless it's specifically set up for that, to be actually develop the skill set to do it well.
Which is why I think specialists are so important in certain areas, right? That have a holistic view of certain things. But, if I tore my ACL and, one of our staff did actually tear his ACL, unfortunately, not too long ago, I'd want to be going to the leaders in that who can take me, if not through the whole journey, they can go, I'm going to do here to here, and then you're going to be in exceptional hands from here onwards. And so at least having confidence in the person or even the team that's supporting you with that, I think that's That's hugely important.
Yeah, and I get a lot that also come in at that 6-month time point, and they are, again, it's not a slight against the physiotherapist or the profession. It just is what it is. She said yesterday or it was a mum, she was like, oh, I want my daughter, she's 15, to return back to sport. And she's a really high level track and field, but loves to play footy and all the other sports at the same time. And she said, I feel like the physio and the ex-phys that she's seeing at the moment is just a little bit light on, and that she's not getting what she needs. So it's something that I come across all the time, that we need to do more with these patients to actually put them in the best position to succeed long term.
Yeah. And so what about, you obviously done some work with meniscus as well. So involving meniscus, not involving meniscus in an ACL, what are you looking at in terms of what would differentiate your programming, let's say, if someone tore their ACL and a meniscus versus just an ACL?
Yeah, so meniscus does change things, mainly in the first probably 12 to 16 weeks, so first 3 to 4 months. Depends on the extent of the repair as well. So you might get a repair that it's big, or it's in a quite a vulnerable position, or there's little blood flow, and the surgeon has said, all right, you're going to be 6 weeks non-weight bearing. You could also get a repair that's only minor, maybe only requires a 1 stitch, or the type of tear, because you can have different types, where it's horizontal, radial, bucket handle, all those kind of things, that they're happy for them to weight bear straight away. So probably the first thing is being really clear on the restrictions, because naturally if someone is 6 weeks non-weight bearing, then they are going to be significantly behind of what a normal ACL would be. Like, we've pretty much put a handbrake on for the first 6 weeks. Yes, you can do a lot of stuff when they're not weight bearing still, but still they're not going to be running at 12 weeks like the normal ACL. Then probably the other things is most of the tears will happen in the posterior horn, or the posterior half of either the medial or lateral meniscus, and the meniscus is more susceptible to high levels of compression, particularly in a weight-bearing position. So they will be still working reasonably hard on the strength stuff, but we can just modify our ranges of motions, things like that, not pushing depth early, just getting them strong in a smaller range of motions, so that we can still work on their strength and function, but not put too much undue stress on the meniscus, because that's really healing up over that first 12 weeks. So we have to be mindful of that we're not overstressing it. And then probably the last thing is meniscus is one of the shock absorbers of the knee, so it's going to be susceptible to impact type loading. So that comes into the running, jumping, and those kind of things. So we're probably delaying that for a little bit longer than a conventional ACL because of those factors. So it's mainly considering the type of, or the extent of the repair and the post-operative restrictions, how much that's going to delay it, the compressive factor in deeper degrees of knee flexion, and then impact-related activities are all going to be delayed off the back of a meniscus repair with an ACL at the same time.
Yeah, okay. And so those are the changes with the meniscus involvement or not, in terms of like it's delayed, it's, we need to be careful about how much force absorption or, that deeper knee work that we're doing. What about non-operative cases? What is your take on people who choose to, because obviously there's some new research out there saying we don't need to operate, you can still return to sport. Like, what's your thoughts on that?
For an ACL mainly?
Yeah, let's go ACL.
Yeah, it's a very topical area at the moment. Like, there's a huge amount of interest, and there's been some big papers coming out. We've got there's now potentially 3 groups. We've got the classical ACL reconstruction, which somebody who is having ongoing instability and giving way in their knee, or has a degree of locking or catching due to a meniscus tear or something, should probably have surgery.
Mm-hmm.
Then we've got the delayed surgery, which is what most people should go down this pathway, which is I should say the option for delayed surgery. So that's 12 weeks of really good structured rehabilitation, monitoring for instability and issues like that as you progress through that. And if they are starting to have those instability events and they're having ongoing functional issues with their knee, then they should probably have surgery. And if they're not, then they don't, basically. So we know that roughly about 50% of people will, at the moment, will most likely require surgery, and 50% can probably cope without it. In Australia, we operate on close to 80 to 90% of ACLs. So we're way out of kilter there, and it's kind of changing. It's changing at the moment, the management of non-operative. So we've got a couple at the moment who's returning back to AFL, another girl she's a bit further down the line as well, and she's doing all her hopping and jumping, and she just wants to get back to recreational stuff, no ACL, no problem. And then we've got another one who's just recently torn her. She's trialing the non-operative pathway as well. So it's definitely happening more, and I'm seeing we are getting success with those people. So I think it should be an option that we should explore. We just need to truly understand when it is the time for somebody to have the surgery, and making sure that they do have a surgical opinion so that they fully understand the risks involved with the non-operative management and the risks involved with surgery, because there's risks on both sides. So we have to get that opinion, and then we have to know when it's not working at the same time. But in a lot of cases, they can kind of go without it.
When they go without it, is this just to return back to sort of recreational activities, or have you seen people return back to, pretty intense sport after non-operative?
Yeah, we have had people go back to competitive level sport, locally competitive level sport. There is a big question mark at the professional level. We're not really seeing it. There are a few in basketball and soccer and sports like that. Not seeing it as much in sports like AFL at the upper levels, because it's such an intense sport. So I don't think there will be too many clubs at the moment who are willing to take the risk on the non-operative management with their elite athletes at this stage. But we'll just have to watch that space. But I think if they're looking to return to amateur competitive level local sport, then that's definitely possible.
And is that because of the reduced loading on the knee in terms of volume? Is that where you kind of draw those parallels from?
Yeah, I think so. I think professional sport is so intense. It's whether it will be able to cope with the demands of not having it. Then there's the factor of it hasn't really been done, so we're not really seeing it as much as an option. The evidence base says that they are at no further risk of OA, no further risk of meniscus tears and other injuries if they go non-operative. So that the worry regarding those factors shouldn't really be the reason why you should have surgery, because you're trying to prevent osteoarthritis, for example. But I guess we'll have to wait and see what happens at the actual professional level.
Interesting. Watch that space, I guess.
Yeah.
Love to maybe need to get you on for an update later to have a chat in a couple of years to see if there's anything new that's come out.
Yeah.
So why don't we move now to osteoarthritis, and that's another, I guess, the knee is your, Gold Coast Knee Group. So the knee is your jam. What specifically do you look for when you're working with people with osteoarthritic knees in terms of education you're providing, exercise that you're prescribing, and are there different types or levels that people should be aware of?
Osteoarthritis is a complex condition because it is a disease basically of the whole joint. It's not just about cartilage wear. You'll have degenerative meniscus issues at the same time. We'll probably have synovitis or or other issues regarding the lining and the joint as a whole. The issue is that, as most people are aware now, there is a significant difference between the presence of radiographic or presence of osteoarthritis on an X-ray and a person's symptoms. So it's just so common for us to see people who have mild to moderate osteoarthritis but have lots of pain, and then see somebody who has severe osteoarthritis and pretty much complete collapse of one compartment and really varus or bowed legs as a result, but they have very little pain. So it's not just about the pathology, and that's where a lot of these factors associated with more chronic pain presentations become more and more relevant.
Yeah. And so then when you're looking at treating someone based on pain or symptoms rather than their scans, what would you be looking to? Let's say I don't know, maybe a case study would be easier. Say I have moderate, maybe high levels of pain in my knee that I feel like is high levels. I'm nervous about moving or using my knee. What would you advise, and what sort of programming things would you be putting in place to help me improve my knee strength, my pain, my function?
Yeah, we have to treat the problem that the person is coming with, for sure. So we cannot neglect that. So we have to actually treat the knee. So there are things that can help manage pain, and they can be on a tiered system. So you can have really easy stuff like slide over braces or ice or taping techniques, massage, all those things that help people manage their pain. They're not going to, obviously it's not going to fix their osteoarthritis, but hey, it might make them feel a little bit better, help with their managing their pain. And it's often something that we can provide education on them to do themselves. So we can look at the pain side of things.
Do you feel like, sorry, just before you move on, do you feel like some of those long-term are more damaging than beneficial? Because I know like ice is something that we say that, maybe don't ice. Obviously it's an analgesic. And then in terms of bracing, is it, creating a crutch for them? Or do you, I guess it's probably person dependent. What do you think?
Yeah, I think that there's obviously a lot of discussion regards hands-on, hands-off, particularly in the physio profession at the moment. And I think people are more resilient than that. And if we provide the appropriate reasoning around it and the education to go with it, that, you have these strategies that help you manage your pain and they feel better because of it, then like it's fantastic. Like I don't think it's going to take away from or provide them with a crutch or something if it helps facilitate them to be more active and do more, because it's never in isolation. Like we're never doing those things as a standalone thing or as something that's the only treatment that we're providing. But if we can influence someone's pain and provide them strategies to help with their pain while we're putting in, the true foundations, which is their strength and mobility and flexibility, all those kind of things, then there's no reason, I don't think, why we should be hesitant about helping people with their pain. And most people understand that they are only short-term fixes for their pain, whether it's ice or liaising with the GP from a medications perspective, that's helpful for them. And if we're educating them on that, this help with your pain, but to really get your knee better, then we obviously need to be doing some exercise because of that.
Mm-hmm. Yeah, no, I love that. And so let's move into the exercise stuff now. What are you prescribing?
So first thing, I try to put it into two buckets. One is physical activity. So that's exercise that's non-specific to the knee, because we know the anti-inflammatory effects of exercise, both from a mental health perspective, building confidence in their knee, actual systemic low-level inflammation. Exercise has a huge effect on influencing that, which is going to have an effect on their knee pain. The more confident they are, the better their inflammatory state is. The more they can move, the better their knee is going to feel. So it's whatever they like, one, because if they enjoy it, they're more likely to persist with it. And obviously whatever is tolerable for them as well. So if they like running, but running is not appropriate, then obviously we can't do that. But there are often other forms that they can do. So they need to be doing some form of physical activity every week. And, that can be the standard, 30 minutes, 4 to 5 days a week, whatever it is, whether it's swimming or cycling or yoga or Tai Chi or Zumba, whatever that is for them, then we need to get them they're moving in some regard. Then the second type is the knee specific stuff. So what are their deficits and what do we need to work on to actually improve the conditioning of their knee? So that might be flexibility related things. So maybe they've got a very poor pro knee bend and they're incredibly tight through the quadriceps, and they might need to do some form of self stretching, or whether it's self massage things because the tightness over the front of the knee is impacting on them patellofemoral joint osteoarthritis. Maybe if it's calf restriction, we will use the assessment to figure out where their large mobility deficits are, and if we can improve those, then their knee will feel better. And then you've got the strength side of things. So it's where it's complicated, because there is questionable evidence of whether we actually need to do high intensity strength training on someone with knee osteoarthritis. Is it the adaptations we get from the strength training, or the act of performing strength training around the knee that is most beneficial? So I think they're different. I don't think someone necessarily has to get stronger for their knee to feel better, but they need to be doing some kind of strength training. So it gets a little bit complex in that regard, but any kind of well-rounded strength program focusing on the key muscle groups around the knee, quads, hamstring, calves, glutes, then if we can prescribe it at an appropriate level, that may cause some minor symptoms in their knee, but it doesn't flare up afterwards, settles down reasonably quickly, then they are more likely to, again, adhere to it because they feel like they're loading their knee, they feel like it's getting stronger and it's targeting the muscles around their knee. But if someone really hates squats, and we think squats are the best exercise for the quads and the knee, then just because they may be the best exercise, if they don't tolerate it or don't like it, then I'm going to choose one of the other 1,000 ways that we can target someone's quadricep muscles. So I think it's, with something like osteoarthritis, you can have a 50-year-old that's highly active that's used to going to the gym, or you can have a 70-year-old that just wants to be able to walk down the street. So it can be tricky because we need to rely on the principles of what we're trying to achieve rather than specific exercises.
Yeah, I think that's hugely important, right? It's not, there's 100 ways to skin a cat. It doesn't matter which way you get there, as long as you're achieving their goals, and also, potentially not inflicting your goals or your approach. If you want to get strong, then you're, biased. You need to acknowledge we all have bias, and your bias might be strength training, but that might be the furthest thing from what is something that they're interested in doing. And so they'll do as little as that is necessary, and then they'll do these, massive walks or whatever.
With something like with osteoarthritis is a chronic musculoskeletal pain condition. It's not an acute knee injury or an acute injury like someone has fallen or had an incident. So the actual specifics of the physical qualities that we're trying to target, I think, are less important versus the patient-centered approach to trying to facilitate somebody to exercise and perform some form of strength training. For example, like after ACL, we have to do plyometric-based activities to improve someone's reactive strength. Like I'm doing that exercise to elicit a specific performance measure or physical measure versus doing if it is a squat for someone with osteoarthritis, maybe their strength might not go up, but I'm building the person's confidence in loading their knee, normalizing their movement patterns, and facilitating a little bit of joint loading, which helps with hydration and lubrication of the joint. So it's not necessarily for the physical quality of that exercise, but the other associated benefits of exercise and strength training.
Yeah, which is why I think it's important that, you said the first category is physical activity, and second to that is knee specific stuff for OA. Excuse me. And I think that's a really cool perspective, because realistically, what we do know is that exercise is beneficial. So whatever they're doing, getting them moving. I love that your approach is probably contrary to a lot of, like you think you're the knee guy, so knees would be something that you froth over, obviously. But then I love that your approach is you know, the human first and understanding the global benefits of exercise needing to take precedence over knee specific loading for OA. That's really cool.
Yeah, I mean, if we look at all the guidelines, so from all the orthopedic associations, the physio associations, like the clinical practice guidelines, the three big things osteoarthritis. One is weight loss. So if we drop someone's weight by about 10%, they can usually have an improvement of their symptoms by about 30 to 50%. So that's not just knee loading. Like, it's not just about the physical load on the body on the knee. It's also about the inflammatory consequences of fat mass and how that contributes to inflammation within the body. So there is a twofold effect there. The second thing is, with most things, is advice and education. So giving the patient a clear understanding of what the osteoarthritis means and what it means for their physical activity, and trying to build up their confidence and ability to trust their knee and what it means for their future. And then the third thing is physical activity and exercise. So exercise, strength training, and general physical activity forms a major component of it, that's for sure.
Yeah, that's awesome. So one thing I wanted to just touch back on that you mentioned earlier was that we know that osteoarthritis means that, you know, there's generally presence of pain. And so you mentioned, you know, that they don't necessarily need to be avoiding pain when they're exercising. Do you have guidelines around what's tolerable, or how someone can tell when it's too much, or if you're a coach, how you can determine how far to push someone and what's going to flare them up either ahead of time or looking retrospectively?
Yeah, I think we need to be careful, because if we do push too hard, then we risk losing them, because if you're a patient and you get asked to do these things and your knee gets unbelievably sore, then you've lost a fair bit of kind of your therapeutic relationship or respect or trust in that relationship. So I think it is helpful to underwhelm a little bit at the start and then build up that education and around it. And it also comes back to the person, because we know people that are, what type of person are they? So there are people that are really hyper aware of their body. That could be in a good way. Like, they know what symptoms are tolerable and what they can tolerate and how much they can push through and what effects they're going to have. And then you have the hyper aware person that they feel everything. One of those people that feel everything, and they get like super worried and like super cautious just because they are feeling something in their knee. So if we have an understanding of what type of, and then you got the other people that just have no idea how to interpret their pain and what it means for themselves. So we have to understand what type of person they are. But as a general rule, we can have an increase in pain when you're doing exercise with osteoarthritis, as long as it's tolerable and acceptable to the person and doesn't cause visible changes in their movement patterns when they're doing exercises. And for most people, that's like 3-4 out of 10.
Mm-hmm. So when you say visible changes, do you mean, like, you don't mean pushing to failure in terms of they're just struggling with the exercise? You mean like maltracking, or what does that mean?
It means like they are using movement compensations to accomplish the task because of their pain. So Gotcha. It's squat, they're offloading a fair bit in their squat, or if they're doing a walking-based task, you can see there's a visible limp. Like, the pain is resulting in them having to change their movement pattern or their movement strategy to complete the exercise. So therefore, it's clear that the pain they're experiencing is having an effect on how they're moving and how their ability to complete the task and their confidence to do it, because they're offloading as a result of that. So that's what I mean in that regard.
Cool. Awesome. Is there anything else around the knee, or I guess, you know, you and I have spoken about this, but why the knee?
Probably just to wrap up that last thing there, if they can have more pain during the exercises, but if it lasts for an hour or two afterwards, more than an hour or two afterwards, probably too much. Or if they wake up the next day and it's super stiff and sore, it's probably too much as well. So we also have to look not just at the time, but then also how do they respond later in the day and then the next day, to get a bit of a guide as well. We can't neglect that. So
perfect.
And then in regards to the knee, I don't know. I just have grown to love it, really. I think
and
it's
so
one of
you feel
those
like
things,
you go.
it's like the more you learn about something, I don't know what's the curve called? The where you're like
You're asking the wrong person. Yeah, I know what you're saying, but the more you learn.
You get to a point where the more you learn, then the more you realize how much you don't know. And then like there's that point in the middle where you
The
think you know,
Dunning-Kruger effect.
Yeah, that kind of thing. You just like get to a point where a lot of the subtleties and the intricacies and the detailing things become really interesting, and you start to work a lot more with surgeons or sports docs and different professions, and I've just started to appreciate a lot of that sort of stuff with the knees, because which is good. I'm not sick of it just yet, so that's a win.
That is a win. Otherwise you may need to change your business name.
Yeah.
I think, Adam. Okay, well, why don't we finish off with, I like to give people some actionable take homes. So for our coaches, what do you think if they're maybe working with some patients with a knee condition, moving through, what do you think are maybe the top 1 or 2 things that coaches could do better or could be starting to implement today based on what we've spoken about?
So we'll go number 1 is, so sports knee, or the more in the athletic population, is we in the later phases are the most important, and you need to be doing some objective testing from either isolated strength testing from a dynamometer, or maybe some jump, hop or force plate testing to gain some objective markers to truly know what the person has to work on before they return back to sport, and performing a really good, solid strength and conditioning program off the back of that to help people return to sport safely. And then number 2, we go the older knees. That population is, yes, we need to strengthen the knee and we need to work around the knee, but it is a chronic musculoskeletal pain complaint, so we need to consider the other factors in terms of their general physical activity, their weight and weight loss, stress, sleep, all those wider health factors that are going to influence somebody's pain.
Awesome. I love that. So succinct. And so you should be with all the research you've done. You've done a fantastic summary today. Where can people find you if they want to reach out, or if they've got either a client with knee pain, if they have a knee condition, where can we find you? Yeah,
the 3 main places will be naturally the website, which is gckneegroup.com.au. Email, you can feel free to send me an email at adam@gckneegroup.com.au, and then the Instagram, which we just put up a lot of at the moment research-based and educational-based content at GC_knee group for the Instagram.
Awesome. Couldn't get the GC knee group, that was taken.
Correct.
Beautiful. All right. Thank you so much for your time, Adam. I really appreciate it. And I know you're not going to pump your tires up, so I'll do it for you. Adam is fucking phenomenal as a knee leading researcher, and the amount of time and effort you've put into the knee and to help create strategies, systems, processes, and then just treat humans as opposed to just knees is really, really awesome to see. So I would really encourage people to please reach out if you do have any questions or concerns. Adam is always very, very eager to chat all things knees. So thank you so much.
No, well, thanks to you, Zem, for having me. It's a real privilege to be on your show with everything you've accomplished over the last few years.
Oh, thank you. I will talk to you soon.
Excellent. Sounds good.
Bye. If you enjoyed this episode, it'd honestly mean the world to us if you could share it with a friend or on your socials, follow and leave a quick review so that we can bring you more real, raw and uncensored stories from industry leaders. We also love hearing your feedback, so please DM us on Instagram at Swift Coaches Academy if you have suggestions for future guests or topics. Until next time, and in whatever you do, move swiftly.